consultants from Sri Ramakrishna Hospital and from the city of Coimbatore and have joined this webinar through online. And on behalf of the management, we all thank you for participating in this webinar. And today we have interesting talks by Dr. Sridhar Gopal, MD, Fellowship in Clinical Hematology, and he is the consultant hematologist and hemato-oncologist and stem cell transplant physician in our hospital. And he is going to talk about the approach to thrombocytopenia, hematological aspects to unravel the myths. This is going to be an interesting topic to all practitioners of medicine. And the second topic is by Professor V.S. Sitharaman, Principal, College of Physiotherapy and HOD of the Department of Physiotherapy of Ramakrishna Hospital. He is going to talk about stroke rehabilitation, which is a common problem which needs attention by all the doctors, and it's a very useful topic for all the practitioners of medicine. And we thank on behalf of the management both the consultants for sparing their valuable time and taking part in this webinar for the benefit of all the doctors. Now I would like to call upon Dr. Sridhar Gopal for his talk. Dr. Sridhar Gopal.
Yes, sir. Thank you, sir. Thanks for the introduction, sir. My screen is visible, sir?
Yeah, visible.
Yes, sir.
You can just enlarge it. Little bit. Can you maximize it?
Maximize.
Yeah, it's okay.
It's okay now, sir?
Yeah.
Okay. So, very good evening to one and all. Thanks for the introduction, sir. First and foremost, I would like to thank the management for organizing such a webinar, which will be very interesting, to discuss and detail about the cases, about what we are practicing on routine daily basis. And again, I would like to thank all the referring doctors for referring all such cases, because whatever I'm going to present now are the real cases, what we have seen. Hematology is one field where we won't get cases just like that. It's because of all the referrals from all the doctors. It may be general physicians, physicians, general surgeons, or whoever it is. It's all because of their referrals where we are able to work up on the thrombocytopenia, the approach to thrombocytopenia, and finally we are able to present all such topic in such a nice webinar. So this is the thrombocytopenia clinical presentations. So there can be the thrombocytopenia as such. We all aware the thrombocytopenia is just nothing but a decrease in the platelet count. The platelet is helpful in primary hemostasis. So when there is a drop in platelet count which results in thrombocytopenia, there can be a number of bleeding manifestations which can happen. But most commonly, what we encounter is the mucosal bleeding. It can be in the form of petechiae or purpura or even wet purpura, subconjunctival hemorrhage. But the most detrimental is the intracranial hemorrhage, because once that happens, it is very difficult for us to retrieve the patient. Other bleedings like any petechiae, purpura, it may not be clinically, just will be present, but it may not disturb the patient anyway. Whereas the intracranial bleed with such a midline shift is going to be extremely detrimental and extremely fatal for the patient, which if not treated is going to be fatal anyway. So next 15 or 20 minutes, I'll be discussing about the causes of thrombocytopenias, and I will be discussing in detail about the case-based approach and how we are coming about the diagnosis from the basic. So I'll just start with few facts. The thrombocytopenia, as we are aware, when the platelet count is less than 1.5 lakhs, the normal platelet count is 1.5 to 4 lakhs. But again, the international working group has currently changed the platelet counts, the thrombocytopenia diagnosis as less than 1 lakh. Anyway, just we'll keep things very simple and basic. So As far as the thrombocytopenia classification is concerned, we will just we will classify into three types, like mild, moderate, severe. The mild thrombocytopenia is nothing but the platelet counts between 1 to 1.5 lakhs, moderate is 50,000 to 1 lakh, and severe is less than 50,000. So the thrombocytopenia is not, or the platelet count is associated with the defect in the primary homeostasis. And the significant, clinically significant spontaneous bleeding usually won't occur despite the platelet count being less than 20,000. Again, why I am stressing it here is many times we come across patients with the platelet count of 1 lakh or 1.1 lakh, which happens in ICU setup. Like mostly, as far as the guidelines, as far as the journal says, more than 40 to 50% of the patients in ICU will be thrombocytopenia at some point of time. It may be because of the infection, it may be because of sepsis, it may be because of disease, it may be because of the drugs, and there are many etiologies which can result in thrombocytopenia. But even though the thrombocytopenia is there, the patient may not be symptomatic. Only the significant or spontaneous bleeding happens only when the platelet count falls below 20,000. Again, the low platelet count may be the only investigations or the only manifestations of the underlying disorder, like say infections like hepatitis A virus, hepatitis B virus, hepatitis C, or HIV. Again, many times we come across patients with thrombocytopenia where they will be unevenfully and they will be asymptomatic. But once we do the viral markers, they can be positive for HCV, and we have picked up few patients in our scenarios. So again, it may be important surrogate marker to monitor the disease, especially as far as the disease activity is concerned, especially because we treat most of the oncology cases. Any patient who is recovering with thrombocytopenia, that means the disease is coming under control. The patient is benefiting with the chemotherapy. So again, the patients, when the platelet counts are improving, that means if the patient is on sepsis, that's a surrogate or indirect marker that the counts, when the platelet counts tends to increase, that means he is coming out of sepsis. Similarly, the thrombotic microangiopathy is so all such is just the platelet count is it's not just a count. We can take it as a monitoring event to monitor the disease activity. So role of history taking, as far as medicine goes, this is very important, because many times we tend to miss certain very clinically significant histories. It may be simple drug what they're taking, but I will show some cases here where it's just the history which clinks the diagnosis. So any patient with thrombocytopenia, we should always check in terms of any fever, any recent infections, especially fever of duration, from what day the fever was there, whether the fever is associated with chills, what is the source of fever, like any URI or LRI, or any sort of urinary infections or something else. Because a fever will be a sole presentation of acute leukemia also. So finally, when the patient is present with this 7 days to 10 days of fever, the patient can land up in acute leukemia, and finally this can result in thrombocytopenia, where the patient will be eventually landing to us. And any sort of bleeding manifestations in the form of any petechia, purpurea, or any sort of mucosal bleeding, or any bleeding from mild trauma. So all these history is very significant, because sometimes the platelet counts will be close to 80,000, but the patient may not have any bleeding at all. This might have been there for years together, where the patient would never even come across or never even aware of, because there was no bleeding or any sort of clinical manifestations. And again, the third, very clinically a significant history is that any family history of bleeding, because some patients can have a congenital thrombocytopenia, especially patients coming from the West, like West Bengal, Jharkhand. Their family or the ethnicity itself is like that. The platelet count should be close to 1 lakh, where where we need not treat anything for the patient. Next is the drug history. The drug history is a very significant here, because many times we miss the drug history, because many times especially in our practice, we see patients who go to the over-the-counter, we get the over-the-counter medications for any sort of pain, which will be most likely NSAIDs, which can result in thrombocytopenia. So again, there are some, even though we say it as heat, which is very common, this heparin-induced thrombocytopenia, which is most of them are aware, but many times many of the clinicians or many of the even doctors may not be aware of the drugs which can cause thrombocytopenia, because there are n number of drugs, literally there are thousands of drugs which can result in thrombocytopenia. Whatever we use, even steroids we use as a treatment for the thrombocytopenia, but even the prednisone is also documented can have a thrombocytopenia. So the drug use is very important. And coming to the recent history of travel, especially in the COVID era, there were patients who had some COVID, and this can result in thrombocytopenia. The patients recovered from COVID, and finally he landed up in thrombocytopenia, for which we have evaluated, and all such events happened in our hospital. And we have to think in terms of any autoimmune disorders like any uh, like SLE or any sort of rheumatological disorders which can result in secondary thrombocytopenia. And we also ask for any loss of weight, loss of appetite, which is very common in malignancies, and especially acute leukemia and MDS, which can result in thrombocytopenia. And in case of pregnancy status, we have to check for the platelet counts, and we have to ask clinically significant like history regarding the thrombocytopenia in the previous pregnancies. Whenever there happens to be thrombocytopenia in the previous pregnancies, again, our diagnosis is very clear. It could be just a gestational thrombocytopenia, which we can consider. Again, the vaccination history, as we all aware, even COVID vaccines have resulted in thrombocytopenia, and some patients even thrombosis, and the thrombocytopenia thrombosis syndrome was also associated, and which we came across recently. So just the diagnostic algorithm of ITP. So as far as the thrombocytopenia is concerned, first and foremost is to rule out pseudo thrombocytopenia. It's nothing but falsely low thrombocytopenia. This has got nothing to do with thrombocytopenia per se. So because of the improper collection or improper storage of the sample, what we are taking, sometimes the EDTA sample is supposed to collect by 1.8 ml or 2 ml. If you're collecting only 1 ml, then this can result in spurious or pseudo thrombocytopenia. This is just a falsely low thrombocytopenia. We have come across even once in 2 weeks regarding the pseudo thrombocytopenia. Most of the time, the patient would have been referred from outside for severe thrombocytopenia. But if we take the sample in a proper manner, that is already sorted out. The diagnosis is already there. So any patient with thrombocytopenia, we have to rule out the pseudo thrombocytopenia. I will say a few issues like few rectifying events on how to rectify the pseudo thrombocytopenia. Once that is confirmed, that is a true thrombocytopenia, then we need to check for the peripheral smear. In that peripheral smear, again, the patients, if the patients have anemia or macrocytosis along with the spherocytes or RBC agglutination, that means the patients can have so Evans syndrome, where there is a concomitant autoimmune hemolytic anemia and immune thrombocytopenia. So the investigations which we need to do for Evans syndrome is like do direct Coombs test, reticulocytes, LDH, bilirubin, and haptoglobin, which will be high most of the times, by which we will get to diagnose of Evans syndrome. Subsequently, when the in the peripheral smear, when we come across any cystocytes or the fragmented cells, that means again the diagnosis is almost closely there. That is, there's nothing but a thrombotic microangiopathy, which can be again a TTP or DIC. How we evaluate further is to look for the bilirubin, look for the PT-APTT levels, LDH, and if at all any feasibility do RMTS, we can do. And coming to thrombosis, as I already said, the heat or heparin-induced thrombocytopenia can also have thrombosis most of the time. That's called HITT. So in such scenarios, we have to involve, like we have to think in terms of the associated drugs which is there, and any patients with APLA, that is antiphospholipid antibodies, which can result in thrombosis, also thrombocytopenias. So again, if at all that patient happens to have leukocytosis with neutrophilia and toxic granules, that means the patient is sepsis most of the time, which can result in thrombocytopenia. Again, for that we need to do some blood cultures to start on antibiotic. Once the sepsis is clear, then thrombocytopenia will recover by itself. Again, when we see the peripheral smear, when we come across a blast or any atypical cells or pseudopelvic cells, then we'll be thinking in terms of the primary matter pathology like acute leukemias, MDS, or lymphoproliferative disorders, which can again need further, which will again require further evaluation in the form of bone marrow, flow cytometry, and other investigations to confirm the same. So ruling out everything, only if it is isolated thrombocytopenia, only here comes the diagnosis of ITP. Why I am stressing here is that the topic why I selected is to unravel the myths of thrombocytopenia. When we come across thrombocytopenia, as far as many are concerned, there will be only two diagnoses from their side. One is ITP, one is dengue. If the patient presents with the dengue fever, then the diagnosis is dengue, and if the patient had a fever 2 weeks before with isolated thrombocytopenia, then it is ITP, and that is how it is being treated elsewhere. And most of them, some patients are even started on steroids, which ultimately resulting in a wrong diagnosis, and subsequently it can result in and significant mortality and morbidity for the patient. And two more things I would like to give some glimpse regarding what is MPV, which is very, very significant in the upcoming slides. MPV is nothing but a mean platelet volume. The normal range is between 7 to 11 femtoliters. Again, why I'm adding it, or why I'm saying all these slides is nothing because like our PGs are also there, so which they will also be benefited. So similar to MCV, what is the mean corpuscular volume for anemia? What we think, where we categorize the types of anemia like macrocytic anemia or microcytic anemia. Similar to that, we also have a MPV, there is a mean platelet volume where the normal range is between 7 to 11. Again, similar to MPV, there is some other term called as IPF, that is immature platelet fraction. The immature platelet fraction is nothing but the reticulated platelets is similar to reticulocyte count what we use for anemia. So which represents the marrow response for the state of thrombocytopenia what we have. So whenever the MPV is more and IPF is more, then our diagnosis is almost clear that is more in favor of ITP, that is the idiopathic thrombocytopenia or immune thrombocytopenia. So this is not the specific text like where we need to do it in a separate way. Whenever we do counts in a Coulter machine, most of them this MPV and MP yeah, and MP and IPF will be already there. So just by looking at the reports, you will be able to pick up the diagnosis. So again, I'm just stressing on one slide regarding ITP because most of the time there is a scenario like where the patient will be treated as ITP most of the time. ITP as such has no any there is ITP is nothing but a diagnosis of exclusion. There is no clear-cut guidelines to diagnose ITP. Once everything is ruled out, only there comes the ITP diagnosis there. So first of all, yeah, yeah. Just because of shortage of time, I'll just move to cases. So case number one is a 43-year-old gentleman from Ooty. Is an electrical engineer by occupation. He had a fever almost 2 weeks before, and he also had a history of myalgia at that point of time. Now he never had any fever or no myalgia. He never had any joint pains, rashes, or skin spot or petechial spots, nothing. No history of any bleeding. He does not have any comorbidities. Neither he don't take any of the native medicines in the past. And clinically, there was no lymph nodes, no hepatosplenomegaly, no pallor, no petechia, no purpura. Oral cavity is normal. There is no wet purpura, and the vitals were stable. Coming to the laboratory parameters, the hemoglobin is 13.7, WBC count is 8,500 with normal differentials like neutrophil 68%, lymphocyte 30%, MCV is normal. Only there is isolated thrombocytopenia. Again, the biochemistry wise, LFT, RFT, LD, it's always normal. So coming this, that is a clear-cut isolated thrombocytopenia. So next question is what's next? How to do? So we did a peripheral smear. The peripheral smear nothing. It showed a full of platelet counts all over the field, which was that's adequate. So there was thrombocytopenia, but the peripheral smear showed huge platelet counts in almost all the fields, which were showing as adequate. So our diagnosis is nothing but pseudothrombocytopenia. So just we repeated the sample in a proper way with the citrated sample, what we commonly collect for a PT APT tube, where the platelet count showed absolutely normal. It was 234,000. So the diagnosis is nothing but a pseudothrombocytopenia, which was missed, and the patient got very much anxious, very much apprehensive because the low platelet count for which he was sent here. And it happens to be just pseudothrombocytopenia for which we have not treated. We just give reassurance and send him back. So the pseudothrombocytopenia can is almost close to 15-20% in case of isolated thrombocytopenia. The platelet basically tends to aggregate in the presence of excess EDTA. When the sample is not collected in a proper way because of the excess EDTA, these platelet tends to get aggregated, which results in pseudothrombocytopenia. It is not associated with any bleeding. Just doing a peripheral smear will be able to pick up. And the simple resolution is to do a citrated platelet count where the platelet counts will be normal. And this is how the platelet, the smear looked. See, there are huge clumps of platelets sitting out there. And not only one field, there are multiple other fields where you can see plenty of platelets. So the diagnosis of this patient is pseudothrombocytopenia. Case number 2 is a 31-year-old lady, G2P1L1, post cesarean pregnancy, married since 6 years, and it's a non-consanguineous marriage, and that is on plus 6 weeks. She had elective LSCS in the past, and again, incidentally, she was found to have a moderate thrombocytopenia of 72,000, which is again confirmed with peripheral smear, for which she was referred here. Again, present pregnancy wise, the first 3 trimesters all were like 1, 2, 3 trimesters all were uneventful. The platelet counts at the time of booking was one normal is 1.8 lakhs, and subsequently after admission she was found to have a platelet count of 70,000. The next day the platelet count is 63,000. The coagulation profile was within normal limits, and for which hematology consult was sought. Apart from mild tiredness, she never had any sort of bleeding, no weight loss, loss of appetite, no exertional dyspnea, and no history of any bleeding also. Again, her past medical history and family history was negative for any sort of bleeding tendency, thrombocytopenia. And the patient, one significant history is that she had given a similar history of previous thrombocytopenia in the previous pregnancy. Hence, our diagnosis is simple. It's it's like gestational thrombocytopenia, for which again she, because at the time of the platelet count of 58,000, she had to be delivered by cesarean because of previous LSES, and she went ahead with LSES. The newborn platelet count was within normal limit. So the diagnosis is nothing but simple gestational thrombocytopenia. So why I'm addressing here is that there are some school of thoughts regarding whenever the patient platelet count is low, especially in pregnancy, like at almost term pregnancy. There are some scenarios where we go across where we tend to do LSES by that. But as such, guidelines says we have to go ahead with LSES just because the platelet count is low. The guideline says that if at all the patients require LSES because of the gynecological cause, then we can go ahead. So coming to case number 3, again, a pregnant lady with multiple history of abortions. She came with a present pregnancy of spontaneous conception. There was no history of any bleeding, no history of any family history of any sort of bleeding. The upla was done. It was triple positive. That is lupus, beta 2 glycoprotein, and anti-cardiolipin antibody, which was positive. The ANA was negative. The diagnosis was nothing but antiphospholipid syndrome. Again, the thrombocytopenia is because of the secondary autoimmune thrombocytopenia. So, after consulting with the rheumatologist, she was started immunosuppression along with LMWH. Despite the platelet count being 50,000, because the disease warranted, after discussing with the rheumatologist, we have started on LMWH. She was on Clexane almost throughout her pregnancy from the time she met with us, and they almost weekly once the platelet count was monitored. She was extremely she was given um, proper care regarding what has to be done sort of bleeding, and she was also added with aspirin from the time of diagnosis. She was monitored with the serial monitoring of platelet counts. Whenever the platelet counts tend to drop less than 30,000, the LMWH was withheld, and after that, when it is more than 30,000, more than 50,000, it was again restarted with LMWH. And throughout the pregnancy, despite the low platelet count, she was continuing with low molecular heparin, and she went into spontaneous labor at 37 plus 2 weeks and delivered a live baby. And there was not much of a blood loss despite being the platelet counts are close to 50 to 60,000, and she was never transfused at all. Again, the postnatal for the patient, the hemoglobin was normal. The platelet count was also almost close to 60,000. Again, but the story is not over yet. What happened again that night? I got a call from that NICU saying that there is petechial spots all over the body for the baby. So there was some oozing from the sampling site also. Again, the platelet count for the neonate was 5,000. So there we did the UHG screening for the brain. There was no history of there was no bleeding. Otherwise, the baby is very active. Sucking reflex is present, and just it was nothing but NAITP. That is neonatal alloimmune thrombocytopenia, where this is because of the passive transfer of the antibody from mother to baby, resulting in thrombocytopenia. So for which, because of the very low platelet count, the baby was given IVIG 1 gram per kg, along with the platelet support, because that time there was some oozing from the sampling side. So subsequently, the next day, the platelet counts went up. The platelet counts slowly recovered, and the baby was discharged in a normal way. So coming to case number 4, again this 63-year-old gentleman who was referred for severe thrombocytopenia. Again, he had some comorbidities in the form of hypertension, for which he is on medications, and he also had dyslipidemia, for which he was on medications. So the current complaints was she was admitted with the generalized tiredness and malaise. There was again no history of any dyspnea on exertion or no history of any bleeding. On probing further, he had some shoulder and neck pain, for which he has taken some over-the-counter medication also. So initially we were thinking in terms of probably the NSAIDs, which would have resulted in thrombocytopenia. But again, this was almost some 2 to 3 weeks before. And again, the laboratory parameters showed the thrombocytopenia of 13,000, which was very severe, and the triglycerides of almost 273. Again, the biochemistry wise, other LFT, RFT, LDH, other B12, iron, and everything was within normal limits. And because of the isolated thrombocytopenia, because we don't have any clear-cut idea, and because of the age, so we went with bone marrow study. The bone marrow biopsy, bone marrow was done, which showed a cellular marrow with mildly increased megakaryocyte hyperplasia. Again, which is this could be still ITP, but anyway, I'm not just convinced with ITP because again we went ahead and was thinking in terms of any other history which we will be able to pick up. And he said that recently is the cholesterol drug for dyslipidemia was altered. It was initially he was taking a rosuvastatin, and finally he has just one before he has changed to ezetimibe. So hence we got a diagnosis as a drug-induced, that is the tab ezetimibe-induced thrombocytopenia. Very few case reports are there regarding ezetimibe-induced thrombocytopenia. Definitely, as ITP could not be ruled out in this scenario. So what we have done is after discussing with patients, and because there was no bleeding, there was no steroids which was given. Instead, after counseling the patient, giving reassurance, we just stopped on. He was advised to stop the afanine drug. Here, the afanine drug is ezetimibe, and then it was stopped. And these are the various mechanisms which can result in thrombocytopenia. Why I'm putting this slide is that there are almost close to 10,000 drugs which can result in thrombocytopenia. There are various other mechanisms which can result in thrombocytopenia, like hapten mediated, fibrin mediated, quinine mediated. So any drug which we name that can result in thrombocytopenia. Even we have come across with paracetamol causing thrombocytopenia. So again, so after stopping this ezetimibe, if you see that the initially the platelet was at 13,000, subsequently it was 24,000. We were not given any transfusions, and subsequently after stopping the drug, the count slowly came up. It went up to 1.2 lakhs after 2 weeks of stopping the afanine drug. So coming to case number 5. Again, this is a 72-year-old gentleman from Ooty. He presented to us with the gross hematuria. Initially, he was treated with in outside hospital for the hematuria, but he had a significant like gross hematuria. So this was at the time of presentations. He had the it's gross hematuria with the petechial and purpuric spots all over the body. And he also had a bleeding PR at the time of presentation. Initially, he was treated outside and received multiple transfusions for the same. And because of that severe bicytopenia, where the hemoglobin was only 6 and the platelet count of 3,000, for which he was referred here. At presentation, he was febrile, pulse was 126, and the respiratory was 22. And the other parameters like the laboratory wise, the hemoglobin 6.8 with a normal MCV, and but the platelet count is only 4,000. Again, the reticulocyte count is more. It is 98%, 9.8 percentage, and the LH is also high. And here the DCT was positive on further workup, and the creatinine was 2.3. Procal was positive. So again, the initial DD, what we were thinking in terms where the sepsis-induced thrombocytopenia, one thing. Second, it could be still the event syndrome, where there is a associated autoimmune hematologic anemia and ITP. Again, USG abdomen was done to look for the cause for hematuria. It showed thickened urinary bladder with internal debris and clot. Again, CTKB was performed, which showed left hydronephrosis with the blood clot, and was diffuse wall thickening of the urinary bladder. So urologist opinion was sought for placing a reagent, but in view of urosepsis as the source. But he suggested that he wanted platelet count to be more than 50,000 for the stenting. Again, in this scenario, we have done a marrow to look for the cause for bicytopenia. So again, the marrow was showed a cellular marrow with erythroid and microcarditis hyperplasia, which was more in favor of Evans syndrome. But again, for this Evans syndrome, the first drug of choice is to go with either steroids or IVIG. The steroids cannot be given in this scenario in view of severe sepsis, procal positive, multiple infections, especially urosepsis. So steroids is almost we can omit it, we cannot give. And again, he also had some financial constraint. So after discussing with the family, we have put up a dose of IVIG, 1 gram per kg. Post that, the date after 48 hours, the platelet count started improving. His hematuria started clearing, and almost the counts also recovered. The platelet count slowly came up to 60, 70, and subsequently the platelet counts recovered to more than 1 lakh. Because the counts recovered, we again asked urologist, and he underwent cystoscopy with the clot evacuation with the left DJ sending, and sepsis also recovered. So on this is the counts for this patient. On admission, it was 6.8, the platelet was 4,000. And on treating with IVIG, subsequently on removing the sepsis, the counts recovered like anything. They went up to almost 1.5 lakhs the subsequent days, and he got discharged. So here the diagnosis is not actually sepsis induced along with the event syndrome. Um, because of the time constraints, I think the one more speaker is also there. I've just put up my just comparison for one slide. So if you see these cases, or it's case 7, 8, and 9, all these patients do have some severe thrombocytopenias with the platelet counts close to less than 20,000. But so if you see the case number 7, like the patient had 30-year-old lady with a fever, fatigability, with the purpuric spots, and petechial rash all over the body. Most of the patients with severe thrombocytopenia here in our cases had some sort of bleeding manifestations in the form of petechial or gum bleeding. And in case number 8, the patients had multiple lymph nodes along with hepatosplenomegaly, which is not elsewhere. So why I'm addressing, or what I'm just as a comparison, I'm putting all these cases just to make sure that whenever patient comes with any sort of history, it's always advisable to do an examination, especially to look for multiple lymph nodes and hepatosplenomegaly, because the multiple lymph nodes hepatosplenomegaly is there, which is more in favor of any acute leukemias which can present with the thrombocytopenias. Again, when we come across any anemias, it's always advisable to look for MCV, where the macrocytic anemia, if it is there with high LDH, which is more in favor of B12 deficiency. And again, as I said earlier, when the MPV is more, which is more in favor of ITP. So these are the set of cases. Because of time constraint, I'm running. If you see the peripheral smear for all these patients, so the case number 1 is nothing but here there was no platelet visible. On further evaluation, it was dengue positive for this patient. So again, subsequently case number 2, there was some few atypical cells which is nothing but acute leukemias. And case number 3 is presence of macrovasculocytes and high MCV, which is because of megaloblastic anemia. So actually, all these cases present with severe thrombocytopenia with some sort of bleeding manifestations, but sometimes it's not necessarily required to do bone marrow for all. And the patients, most of the patients, if the patient is not bleeding, need not require transfusions also. So finally, as I said, the case number is nothing. Case number the 7 is nothing but the dengue-induced or viral-induced thrombocytopenia. Any virus can result in thrombocytopenia. Even we have picked up cases with COVID-induced thrombocytopenia. Again, whenever the patient is present with liver and spleen enlargement with multiple lymph nodes, we should do a peripheral smear which can pick up atypical cells of blast most of the times, which can result in acute leukemia. Again, when there is a macrocytic anemia with the macrovasculocytes and high LDH with a high indirect bilirubinemia, which is more in favor of a beta deficiency resulting in thrombocytopenia. Sometimes the megaloblastic anemia, here we have picked up cases even with the platelet counts of 2000. 2000 with hemoglobin 1.9, one patient was there. He finally happens to be megaloblastic anemia. So the take-home message for my talk is that always when there happens to be some thrombocytopenia, it's always advisable to check for other lineages as well, because most of them we tend to see only thrombocytopenia. We will miss out other lineages like especially hemoglobin and WBC. When there is a decrease in all lineages, like when there is anemia, when there is leukopenia, when there is thrombocytopenia, which can be aplastic anemia. Again, I had some cases because of time constraint. I'm not putting such cases, but that could be just the representation or presentation of the aplastic anemia which can be there. Again, all thrombocytopenia need not be ITP or dengue induced or viral induced. The dengue and ITP is, yes, is still possible. It is there, which is common, but we should also rule out the other causes of thrombocytopenia before putting a diagnosis ITP. The thrombocytopenia may be just a surrogate marker for the underlying disorder, especially in case of sepsis, especially like autoimmune disorders, especially like SLE or APLA. So even infections like HIV, hepatitis B, HCV. So all these patients need to be further evaluated before coming into any sort of diagnosis. For the drug-induced thrombocytopenia, the offending drug should always have some temporal association. That means any patient, our implemented drug should have been given to the patient at least for 7 to 10 days. There are some exceptions for this, especially in case of heparin-induced thrombocytopenia. Whenever this could happen even with a single dose of heparin which is given in this scenario, in this episode, sometimes the patient would have received almost some 5 years before during the previous surgeries, and the patient would have developed some antibodies. But whenever the patient gets exposed to a further dose of heparin, especially at this time, there can be some anamnestic response where there will be excess of antibodies which can result, which will produce, which can result in a sudden onset thrombocytopenia despite a single dose of heparin at this episode. So, apart from this acceptance, there should be a temporal association of the offending drug, which usually have at least 7 to 10 days of the drug. All thrombocytopenias did not require a bone marrow study because sometimes mild thrombocytopenia, which may be because of infection, which will be subsided, which will improve once the infection subsides. Again, but all the mild thrombocytopenias will require evaluation, but many times need not require treatment. Again, why I am stressing is that just because one time the platelet count is 1 lakh, we have picked up patients with even the last week we picked up a patient with APML with that is acute promyelocytic leukemia with the platelet count of 1 lakh. Initially, the patient had 1 lakh. Again, he was left just like that. And subsequently, the next 3 days, the platelet count when he came here, it was only 40,000. And subsequently, we did a marrow. It happened to be acute leukemia, that is the APML. So all these thrombocytopenia will require evaluation, but many times, if the diagnosis is there, we need not treat for some patients. So with this, I will like to conclude this presentation. I'll be happy to take up the questions, if at all any. Thank you.
Thank you, Dr. Sridhar Gopal. It was very interesting and informative, and you made this topic interesting.
Thank you, sir. Thank
A
you,
way
sir.
of presenting many cases, and we had so many take-home messages. And any thrombocytopenia should not be just like that taken, and it should be investigated further, and each case should be dealt with individually on its merits only.
Yes, sir. Yes.
And it can vary from common ITP to from dengue to drug-induced and even to leukemia and megaloblastic anemia. So all these messages will be useful to all the medical practitioners, and your way of presentation was very good.
Thank you, sir.
Thank you.
Thank you for nice words.
We'll have the question and answer sessions at the end of the second lecture.
Okay, sir. Sure, sir.
And I would like to call upon Professor V.S. Sitaraman for his talk. Dr. Professor Sitaraman.
Good evening, sir.
Yeah, good evening.
My screen is visible, sir.
No. Yeah.
Good evening to all. I thank the management and medical director to share my views on stroke rehabilitation on this wonderful platform. But stroke, by the definition, it's a rapidly developing clinical signs of focal disturbance of cerebral functions with the symptoms lasting 24 hours or longer, or leading to the death with no apparent cause other than of vascular origin. And epidemiology and etiology, stroke is the fifth leading cause of the death and leading cause of the long-term disability among the adults. The type of stroke is significant in remaining survival. Of the patient with stroke, hemorrhagic stroke accounts for the largest number of deaths with mortality rates of 37% to 38% at 1 month, whereas ischemic stroke have a mortality rate of only 14.7% at 1 month. Several rates are drastically lessened by increased age, hypertension, heart diseases, and diabetes. The loss of consciousness at the stroke onset, lesion size, persistent severe hemiplegia, multiple neurological deficit, and history of previous strokes are also important predictors of mortality. Strokes can be classified as etiological categories, vascular territory, and management categories. Due to the time concern, I'm going directly to the I'm directly going to the physiotherapy assessment part. The assessment place in the two places where the patient is at present. The patient at present, if it is an acute case, the patient will be in intensive care unit. If the patient is in from the intensive care unit, once the condition has been stabilized, they can be shifted to the wards. In case of intensive care units, the physiotherapy patient history, present and past plays a vital role. Evaluation of higher functions, conscious, memory, orientation, and speech, muscular system, muscle tone, deep tendon reflex, plantar response, muscle power, balance and gauge. Sensations, superficial, deep, and cortical sensations should be evaluated. Vision, coordination. If the patient is able to walk, then go for gait evaluations. The problem list which we'll be facing for the stroke patients are tone abnormalities, either spastic or flaccid, synergistic pattern, dysarthria, dysphagia, agnosia, visual disturbances, sensory disturbances, tightness and contractures, imbalance and incoordinates, gait abnormality, postural abnormality, and functional disabilities. This may vary according to the types of lesions. Our short-term goals will be to prevent bed rest complications, to prevent respiratory complications, to normalize the tone, to improve sensory functions, to improve flexibility and joint integrity, to improve strength, to improve motor learning, oromotor rehabilitation, speech swallowing, facial muscle strengthening exercises, to improve coordination and control of voluntary movements. In case of long-term goals, to improve and train gait, to improve postural control, to improve balance, functional re-education for ADL activities. By short-term means, what are the things we are going to treat as a therapist approaches the treatment on the affected side. Initially, we are starting with passive movements to maintain the muscle pathology. Positioning of the patient plays a vital role to prevent bed rest complications, to prevent pressure sores, and to prevent the subluxation of the shoulders, and mainly to prevent antispastic positions. Bed mobility exercises are taught to turn and go up and down in the bed, pelvic bridging, calf squeezing to prevent DVTs, calf stretching, foot drop split to prevent ankle dorsiflexions, sensory education therapy, long sitting, in posture correction in all starting positions, high sitting, first train with the static balance, then go for dynamic balance. Next, going with standing with supports, balance training, again with static and dynamic. Depending on the muscle tone, the progression from passive movements to the active assisted exercises, active assisted to active exercises, and active exercises to resisted exercises. The physiotherapy intervention to improve the activity is two types: postural control and balance, training with visual feedbacks. Postural control and balance. Postural control can be viewed on body functions and structures on activity level. It basically depends on the base of support, supporting surface, and sensory supports. First, initially, the base of support will be longer, then gradually the base of support should be shorter down, and supporting surface, whether it's a stable or unstable surface, and sensory inputs, it depends upon the eye closed or eye open. So this unstable surface where we are training the patients for postural gait balance. And next we are training with the visual feedback. Then it is mainly to improve the balance in post-stroke. The balance is detected either with the force platform biofeedback. Okay, where the patient is standing in the force platform. With the force platforms, the posture corrections and balance trainings are trained. And next other screen is it's training on the visual feedback by their own vision. The patient actively correct the postures. Next, to improve the gait and locomotions, talk specific overground locomotor training. Locomotor training using treadmill without harness, body supported motorized treadmill training, robotic assisted locomotor training, high intensity stepping, functional electrical stimulations, motor imaginary and virtual reality, orthotics and assistive devices for lower extremities, and wheelchairs. Overground locomotor training is walking in all directions, walking on the different surfaces, stair climbing, step over steps. Locomotor training using a treadmill without a harness is a support has been shown to improve the maximum gait speed and temporal spatial parameters of the gait for a person in all phases of recovery. The ability to increase the walking speed on treadmill results in the gait speed improvement as well as the increase in the step width. With body support or with the harness, it motorized treadmills, this allows the clinicians to use a closed group training environment to improve the recovery of walking ability after strokes using intensive task-oriented training. Normal kinematics and phase relationship for the full gait cycles are promoted, including limb loading in the mid stance, unweighing, and stepping during the swing. Overhead harness is used to support a portion of the patient's weight, example 30%, progressing down to 20%, and then 10%. The harness controls the upright position of the patient in the absence of good postural stability and reduces the fear of falling. So these are patient is training with the harness, with the treadmill, and the next part is with the steps. Then functional electrical stimulation is mainly given to the to improve the dorsiflexions of the ankle, so thereby to prevent the circumflexion gaits. The electrodes are positioned in the anterior tibialis and peroneus longus muscles, and the sensor is attached to the patient's shoes and transmit the wireless signals to the stimulator. The level of stimulations can be adjusted by the handheld remote control, which allows the patients to turn on and off the devices. These are the pad electrodes where it can be placed during the gait training. That is mainly to stimulate the dorsiflexions to prevent the circumflexions of the gait. This is a functional electrical stimulation used to train the ADL activities for the upper limb functions. Then VR therapy. This allows the stimulation of the real world environment for walk training, imaginary walking, and has been studied at this strategy level and the task level. At the strategy level, the individuals post-stroke imagine walking and changing the kinematics and kinetics of their movements. The motor imagery is the portable and low cost. To use this intervention, the importance to determine the person post-stroke is to be able to imagine. This can be assessed by administering the kinetics and visual imaginary questionnaires, which has been validated for the person's post-stroke. Next, orthotics and assistive devices for lower extremity. This is where the foot drop splint plays a vital role. The ankle is kept in a neutral position, so this will allow the circumdactory gait and will facilitate for the hip flexion and knee flexion walking. Then the wheelchairs. The persons with stroke exhibit the partial abnormality asymmetries, which needs to be carefully evaluated. This includes the following: lateral trunk flexed to the weaker side, head may be flexed to the weaker side, the pelvic posterior tilt with some obliquity, lower extremity rolled out into the abduction and external rotation. If spasticity is present, increased hip extension and abduction and internal rotation with the knee extension may occur. Foot drop is typically plantar flexed and inverted. Upper extremity held flexed and adducted to the trunk with increased elbow, wrist, finger flexion with flaccid, and the shoulder is subluxed with the hanging, dragging into the dependent positions. The patient needs to be instructed in the methods of propulsive and given the opportunity to practice on the level and varied surfaces and transfers in and out of the curve, and should be practiced out in the prospective wheelchairs. The wheelchair prescriptions will vary according to the patient dependence. And to maintain to reduce the spasticity, application of cold, massage and electrical stimulation. Cold slows down the nerve conductions and decreases the muscle spindle activity. These factors can lead to a temporary reduction of the tone. Cold can be applied via ice packs or ice massage, duration of 10 to 20 minutes, or using vapor coolant spray. The effects of the cold are short-lived, generally lasting for about 10 to 20 minutes. Functional electrical stimulation can be used to target the weakened antagonist and works to decrease the tone through the effects of the reciprocal inhibition. Functional electrical stimulation has been used with some success to decrease the tone during the treatment time. Then to improve the sensory functions, the different textures are applied through the patient's skins to feel the different sensations of the patients. Next comes the mirror therapy, is to improve the detection of the light touch, pressures and temperatures, thermal stimulations, and intervention for improving the rate of recovery of the sensations. Intermittent pneumatical compressions for improving the tactile and kinetic sensations. Hemianopsia and unilateral like that, the therapist needs to maximize the patient attention by optimizing the visual, tactile, and proprioceptive stimuli more on the affected side. These can include the stroking, brushing, tapping, vibrating on the hemiparetic limbs. The therapist also needs to constantly reorient the patient as inattention develops. The patient with very low levels of arousal are also to be less responsive to the therapy effects. It's important to teach active visual scanning, movements through the turning of the head and axial trunk rotations more on the involved side. Cueing, that is visual, verbal, or motor cues, is used to direct the patient attention. For example, a red canker line can be trapped on the floor and the patient directed to visually follow the line from one side to the other. Supportive devices for proximity is therapy should minimize the sling using during rehabilitation. Sling may be useful for initial transfers and gait training. Slings that are positioned in the upper extremity inflection are less desirable and should be used only for the selective upright activities and only for the short duration of period. No one sling is appropriate for all the patients. Selection and use should be carefully evaluated and sling effectively carefully re-evaluated. Effectiveness of alternatives to use the sling should be considered. Humeral tapping, neuromuscular electrical stimulations can be used to prevent the shoulder subluxations. For the patient using wheelchair, an arm board or lap tray can be provided for the flaccid arm. The lateral elbow guard or a straps may be necessary if the patient arm slips off the sides. The mirror therapy is a therapeutic intervention that focuses on moving the less impaired limb while watching its mirror reflection. A mirror is placed in the patient's mid-sagittal plane, presenting the patient with a mirror image, his or his affected limb, where his hemiplegic limb. It is believed that mirror neurons helps the creation of illusion that affected the hand is moving. It can be practiced in a unimanual or bimanual mode. For patients with stroke, mirror therapy has been shown to improve lower extremity recovery and ankle dorsiflexions, upper extremity recovery and distal motor function, as well as the recovery from the heavy neglect. So these are mirror therapy where the mirror is placed between the both the arms and non-painful limb. We ask the patient to move. That will provide the illumination in the brain. Electrical stimulations can be applied for the persons with a stroke for the selected specific programs. Neuromuscular electrical stimulation is shown to improve the ability of the muscles to exert force by preferably activating the fast contracting motor units. Effective treatments results have been reported for improving functions of the deltoid supraspinatus muscles where the glenohumeral alignment was improved and subluxation reduced. Optimal results have been obtained when they combined with task-specific training. EMG and NMS to the affected wrist and fingers extensors have been shown to improve the motor functions of the paretic arm, hand activities, and active range of motions. Robotic assisted training has been developed to assist the patient with moderate to severe major impairments in improving upper extremity functions. They are used in conjunction with the task-oriented training and motor learning principles. Robots work to restore the lost motor functions and include pneumatic actuators to power the devices or passive robotic systems with elastic bands or strings. Reach and grasp release movements are typically targeted. They can be unilateral or bilateral. Okay, these are robotics where you can start with single limb or bilimb. Next, strengthening exercises to the weakened muscles. Then task-specific training for upper limb muscles where to perform his ADL activities. Okay. So these are some of the principles which we apply for the stroke rehabilitation, but the principles may vary from patient to patient. That depends upon the conditions and age. And the recovery will be depending upon the age of the patients. Thank you. If you have any questions, you can just raise.
Thank you, Professor Sitaraman.
Yes, sir.
Thank you for your nice and interesting lecture on stroke rehabilitation. Now, any questions, interactions from the audience to both the speakers, Dr. Sridhar Gopal and Professor Sitaraman? Professor Sitaraman, all these rehabilitation equipments are available in our hospital.
Yes, sir. All these are available in our hospital, sir.
We are practicing.
Yeah, we are practicing, sir.
It is done as outpatient also.
Yeah, it can be done in outpatient and inpatient rehabilitation service can also be provided, sir.
The recovery depends upon the density of
Lesions, sir. It depends upon the type of lesions and age of the patients
yeah.
and the extent of the lesions.
Any questions from the participants? Dr. Sridhar Gopal, how long we can wait? The level of thrombocytopenia for a transfusion or some other acute management.
Sir, in general, recommendation says until 20,000 we can wait, sir. So we can wait for the platelet count, sir, because we can just serially monitor the platelet count. If the patient is asymptomatic and there is no bleeding manifestations, we can wait till 20,000, sir. But if there happens to be some bleeding, then the count is not a criteria, sir. Then we have to transfuse him if there is suspicion for thrombocytopenia, because there can be some qualitative defect also, sir. Especially in patients with Bernard Solier, there can be quantitative as well as a qualitative defect, where the platelet counts, even if it is there, it may not be functional. In that scenario, then we have to transfuse. Their count is not a criteria. So it depends upon the diagnosis and depends upon the scenario. If whatever happens to be patient happens to be asymptomatic, no history of any no bleedings, or the patient is clinically stable, we can wait, sir. We can wait even till less than 20,000. Sometimes I'll wait even with 10,000. Because ITP patients, even if you transfuse, because there are some preformed antibodies which are already there. So there, just even if you give 10 or even 20 platelets, these platelets are going to be destroyed in a matter of minutes. So it won't be of much benefit at all, sir. So it depends upon the diagnosis, the clinical condition of the patients, and then we can transfuse based upon that, sir.
As I said in your topic, most of the mild thrombocytopenia doesn't need any management.
Yes, sir. Yes, sir. We just want to evaluate to get the diagnosis. If a diagnosis is there, we need not worry at all, sir, because many a times it will be just a coincidental finding, sir. Because we come across at least 2-3 patients per day where there can be some incidental thrombocytopenia. Incidental thrombocytopenia, just because they have done a test, they would have found some thrombocytopenia close to 1 lakh, maybe 1 lakh 10,000 or something like that. But the patient is not having any fever, any loss of weight, any loss of appetite, no history of any nodes. In that scenario, on even examination, there is no hepatosplenomegaly or any lymph nodes. So I will just give you reassurance. Just wait, repeat after maybe a week or so. Check the trend, and then we can guide the treatment accordingly. In hematology, single test may not be sufficient, sir. That's why we are more like lab oriented. Because just because doing a single test, we may not be able to pick up the disease most of the time. So we need to monitor serially, at least for maybe once in 3 days, once in 4 days. We have to check for the trend in the platelet counts rather than a single count. If at all the patient happens to have an increasing trend in the platelet count, that means the patient is improving, irrespective of the diagnosis, irrespective of the disease. So once the counts are improving, that again it's just a marker of signs of improvement for the patient. So we just want to closely watch for the patients, the clinical scenarios, and then we have to plan accordingly, sir.
Okay, Sridhar.
But in general, I just give a reassurance to the patient, because most of the patient is very much apprehensive. Because outside they would have said that because the platelet counts are maybe around 80,000, there's a chance of bleeding, and he will come in a hurry to us. So we just give some reassurance, make the patient stable, like give reassurance, talk about what are the signs or symptoms when we need to worry about, what are the signs of bleedings, what are the dire emergencies or flag signs in as far as thrombocytopenia is concerned, and then after that we will just take it from this.
Thank you, sir.
Thank you, thank you.
Any other discussion by any participant? If there are no more questions, I thank Dr. Sridhar Gopal and Professor Sita Raman for their lectures today, sparing their time and obliging to the management. Thank you, both the doctors. And I thank all the participants of this webinar. And today we had probably one of the highest number of participants today. And we thank all of you. And we hope to meet you next month in a similar webinar. Thank you, all of you.
Thank you, sir. Thanks a lot, sir. Thank you, sir.
I thank Mr. Murali and his marketing team and the PR department for their actively involving in this webinar arrangements. Thank you, Murali.
Thank you, sir.